after tumor excision. Thank you. My acknowledgement to my mentor, Dr. Swati Kaliki, for teaching me ocular oncology and for sharing few patient photographs. Thank you. So we will take up the questions at the end. I will request Dr. Dipankar to give his talk on histopathology of conjunctival tumors.
Good morning, Dr. Everyone, and Dr. Anusha for giving me the opportunity. This was talk supposed to be taken by Dr.Ruchi Mittal, but she could not come, so I was asked very lately to present these cases. My presentation will be a clinico-pathological, so some of the slides may be no repetition of the same thing. I do not have any financial interest in any of this material present here. So already they have shown you a case of a pyogenic granuloma. So infection, previous surgery, or trauma can cause this sort of vascular lesion. And you see a big vascular bloody lesion here. Vascular bloody lesion here. And this is a pyogenic granuloma. Now, as a histopathologist, I think something is there. As histopathologist, we require to know that whether it is a capillary hemangioma or a pyogenic granuloma. Pyogenic granuloma will have a small vascular channels with inflammatory cells, whereas a pure capillary hemangioma do not have a inflammatory cells but a small vascular channel as well as the endothelial cell proliferation. Now, as Tarjani has shown in our slide, again, something is wrong in the something Dr. Tarjani has shown in a slide. There may be various masquerades. For example, this is a superior limbic keratitis. No, sometimes it can masquerade where we need to see thyroid and other things. Now, see, this is everyone here can diagnose this. This is a sessile papilloma. What is important of a sessile papilloma is that the cause of HPV is not there. In pedunculated papilloma, you get a HPV positivity. And this is most a pedunculated papilloma where you see a acanthosis and other epithelial changes with a central fibrovascular core here. Now, sometimes in surface lesion, there may be a small cyst, which can be a implantation cyst or some traumatic cyst or a epidermoid cyst. Epidermoid cyst has a lining epithelium but does not have a content here, unlike an inclusion cyst. Now, see, this is again a subconjunctival lesion showing here, but history is very, very important. There is a trauma. You can well appreciate there is a change in the iris. Lens is not there. Lens has dislocated subconjunctively. It's called phacocyl or subconjunctival implantation, where you have to give an incision and bring out the subluxated lens. Now, this is a very, very interesting case, just to correlate how the imaging is important along with the histopathology. This is a 36 years old male with redness and pain with injury, a lesion looking like a pterygium lesion, and it was excised, and the surgeon excised it and sent to the pathology. In pathology, we have diagnosed as a conjunctival squamous cell carcinoma. By 6 weeks' time, there was invasion in the anterior chamber as well as inside these, and you can well appreciate what Dr. Anusua and showed that the surface changes in the ASOCT as well as in the UVM, there was a changes, and this showed that there's an involvement in T2 weighted images. You can see there's a ciliary body involvement in this. Now you see this was diagnosed as a squamous cell carcinoma invading to the intraocular portion, and this is, you can see well exudaretinal detachment in the area here in the gross specimen. And you can appreciate the tumor migration, intrascleral migration of the tumor from the outside it has taken place. And the vascularity around the tumor was very high, along with the dendritic cell presentations. Now you see the entire ciliary body region, there is involvement with keratin spur with a invasive squamous cell carcinoma. These are the diffraction photography of the of involvement being shown. Just to compare whatever they have showed, both in the MRI as well as ASOCT, in UVM, histopathology, in the gross pathology and histopathology in diffraction and the H&E section, the involvement could be documented. So this was an invasive squamous cell carcinoma masquerading as a uveitis with a past history of pterygium excision. So pterygium excision, all have to be aware. You have to send the specimen to the pathologist for the diagnosis of any underlying tumors. This already covered, these are some of the OSN picture. Again, a whitish one and the pigmented one can be a squamous cell carcinoma. What is important here? What is wide margin dissection? That's very, very important. Anusua has shown rightly she has put a incision mark, but I feel you should do a rose Bengal staining, because in my lab, what I experimented with this, see this is a tumor and this is the area what percolated by rose Bengal. So you need to take a tumor margin from here, 2 or 3 milligram from here, not from here. If you take here, again the margin can contain the tumor cells. So you do a rose Bengal, see the extent of the tumor or the invasion, then you take a safe margin from there. This will give you a better dissection area. So as you know, pterygium you have to see this is a dysplastic area in the pterygium, much more dysplastic area. So whatever we have seen pathologically, the dysplasias, this can be a mild dysplasia, moderate dysplasia, or severe dysplasia, depending on the involvement. If it breaches the what you call the basement membrane, then it's an invasive squamous cell carcinoma. Again, this is either a papilloma or a tumor. See, this is involvement here. Some of the tumor has invaded the substantia propria where you have to dissect it. Okay, this is again a big keratin pearl that has been seen. Sometimes squamous cell carcinoma, a variant called a mucoepidermoid carcinoma or mucinous cell carcinoma may be there, where you need to do a spatial stain to see, because this has a aggressive involvement. Again, a squamous cell carcinoma. If you are doubt, again you can do a simple conjunctival impression cytology to see the abnormal dysplastic cells. Again, what Tarjani and Anusua showed, the keratin. This is, I have seen in just 1 month back, no? This is obvious keratin is there, and you have to think it as squamous cell carcinoma. You have to do under frozen section biopsy, okay, for the margin clearance in this. Xeroderma pigmentosa, if you see, various tumors, squamous cell carcinoma, basal cell carcinoma, other tumor may be there. Again, this was a other eye we have seen it. And what we have done is the conjunctival impression cytology to say that these are the dysplastic cell. Again, the tumor was dissected out, showing a conjunctival. Now we see this lymphoma, the squamous, the lymphoma. Now, Tarjani has shown if it's a bilateral one. See, this patient has a lid shaking bilateral, and there is a salmon patch appearance. So it's obviously a systemic or lymphoma that is happening in this patient. This patient had a lymphomatous cell, and CD20 was positive, which shows that it's a B-cell lymphoma. Patient received both radiation and chemotherapy at Tata Institute, Mumbai. Again, this is a salmon patch appearance, and same lymphomatous cells, which is CD20 positive, CD3 negative, so it's a B-cell lymphoma. Now again, a mild, smaller one, which is outpouching biopsy was taken, and this showed a lymphomatous cell with CD20 positive. Sometimes oculocutaneous pigmented lesion can be there, for example, or nevus or ota, but only conjunctival nevus will not have an intraocular tumor. That's one point. But if both sides is involved, it can have an intraocular tumor. You have to monitor these cases. The conjunctival melanosis can be a surface epithelium. For the nevus, there can be a nevus, even developing within a pterygium. There may be a marginal one and a deeper lesion here. What is important? The junctional component, which is there in other nevus, for example, lid nevus, okay, skin nevus, is not too much in conjunctival nevus. Okay, it's usually usually in the substantia propria, okay? But some, in very rare cases, we can get a junctional component in the conjunctival nevus also. Melanoma, if you see the extended growth, as I'm just finishing. Again, you see the amelanotic and melanotic component. What is important is that you have to understand the nodular other varieties of conjunctival melanoma which is there. And here the calendar classification does not work. Even the Clark classification and Breslow's classification, sometimes like lead, it can be applicable here into some extent. And here this patient has a involvement inside that. So melanoma will be HMB45 positive. And this is again a melanoma cases. You can well appreciate the vascularity. Now all pigmented lesion cannot be a nevus or a melanoma. For example, if you see like this with the tracking of the blood vessel, it can be an Axenfeld loop. Okay, the nerve one, and if you do a dual staining here, you can get a positive. Thank you for patient.